Wonderful to be back here at Yale. I was remembering when I saw my friend Kaveh Honush here that the last time I was here I had just come out of a human rights investigation in Zimbabwe. That was a tough ride. Here I've just come from Baltimore, so a little bit easier. What I'm going to talk with you about today is this really very unfortunate reality that globally and in the United States, the HIV epidemics among men who have sex with men, gay and bisexual men, really are on a very different trajectory from the rest of global AIDS. And the reasons for that are complex. I think they're important and interesting from an epidemiologic perspective. And I think inform what we need to do for the future. And I'm gonna talk as we go through this about the epidemiology, about the burden and risks, about some stochastic models that I think will help explain some of our thinking about these epidemics. A little bit about the disparities with African American MSM, but also black MSM in Canada and the UK. Because I think that those sub-epidemics, which are so severe, really help explain the bigger picture. And then we'll talk about prevention and care and responses. And then finally, I want to end talking about the human rights components of this, because both in the US, but certainly in so many countries, we are not going to get much further with HIV prevention, treatment, and care without advancing the human rights agenda for sexual minorities. I think that is very fundamental. Let me just say, before I jump into this talk, that most of what I'm going to be presenting to you today, not all, but much of it, comes from work we have done over the last 2 years for a special issue of The Lancet, which I guest edited with several colleagues, Ken Mayer from Harvard, Patrick Sullivan from Emory, Jorge Sanchez from Impacta in Peru, and for which we had a number of really spectacular lead authors. Patrick Sullivan led the prevention work you're going to see. Gregorio Millet, CDC in the White House, did the work on black MSM. I led the epidemiology investigation, and then the modeling was done by our colleague Steve Goodrow, University of Washington. So I just want to acknowledge all of them up front and to say that this is really work that builds on those 2 years. So let's start off with the burden of disease. And I think I like to start sometimes with the take-home. These are the take-homes for this burden of disease exercise. And basically what we see is that these epidemics are still expanding, by which I mean there are still, wherever we have incidence data, there really are rising rates of new infection in high and low-income countries. And these epidemics are really marked by, consistently, by high burdens in young men, rapid spread, clustering within networks of MSM. That's going to be a very important part of trying to understand these epidemics. High frequency of dual and multiple transmitted HIV variants. It's molecular evidence that really describes the epidemiology. I'm not going to go into the molecular epi in the interest of time, but it is in the Lancet paper that you'll be seeing some data from. And they appear to be driven by high per act and per partner HIV transmission probabilities, by the sex role versatility of men within sexual networks, which turns out to be a very important component of this, and by network and structural level risks that we'll get into. The methods for this work is basically comprehensive reviews of all the available data globally from 2007 through the end of 2011, systematic reviews of molecular epi, and then this modeling exercise using a stochastic agent-based model. Oh, good. I was just about to say, I hope you can see that, but it's quite clear here. So this is the summary data by region of all of the available HIV prevalence data. These are pooled, adjusted levels. And what you're looking at here is, in purple, is the HIV prevalence from the best available UNAIDS Global Fund data for reproductive age adults by region, and then the rate in MSM in the same regions. Right? So there is remarkable consistency here wherever you look. This is sub-Saharan Africa, of course the highest burden of disease in all populations, but also an extraordinarily high burden in MSM. These are the 95% confidence intervals around these estimates. So even though the data are spotty, and in some areas like the Middle East and North Africa, the confidence intervals are quite wide, they never approach anywhere near equity with the general population samples. This is East Asia, with quite low general population prevalence, but still a high epidemic. And this, unfortunately, is the Caribbean, a region with relatively high rates in heterosexuals, but as you can see, an extraordinarily severe epidemic in MSM. This is what it looks like when you put essentially the same data on a global map, but now looking at prevalence estimates. These are pooled prevalence estimates, adjusted for size. The red color is over 15% prevalence, so those are the highest burdens of prevalent disease. You can see, unfortunately, that that includes the US, a number of countries in southern, eastern, and West Africa, pretty much all of the contiguous countries in Southeast Asia. But as you can see, high burdens globally. Now, these are the available incidence data through the end of last year. There is much less of this altogether. I think we have something like 15 countries represented, about 20 or so populations. These very high outliers are available data on Kenya. There is one incidence point for the whole of Africa, extraordinarily high burden, and the same emerging from China. This slide now needs to be updated because just this week there was incidence data from the Bangkok cohort, the MOPH CDC, and that unfortunately also shows very high incidence burden indeed. But it's a very incomplete map. This is from the call to action paper at the end of this series. And what you're looking at here in blue is where there's available data, and in white is countries that have never done an incident assessment. Now, it is 30 years into the HIV pandemic, and at the beginning it was known that this was an extraordinarily high burden disease in men who have sex with men. So still a long ways to go, and you can see for yourselves where the clustering of really the complete absence of data is. So what about risks for HIV infection? Well, the individual level risks are well characterized. I won't go into those here, but suffice to say that they are increasingly insufficient to explain this extraordinary divergence in epidemiology. The network level risks have been looked at, and those, it turns out, really are very important. MSM networks tend to be larger than for other sexual groups. They are lower density. Those findings have been found in MSM networks in China and Australia and among racial and ethnic minority men in the US. And then, of course, there are structural risks that are really very different, and we will save some time to go into this near the end. But there is emerging data that structural factors like criminalization of same-sex behavior between consenting adults, stigma, enacted discrimination in healthcare settings — I'll show you some data from Africa on that — issues like blackmail and fear of disclosure continue to really be structural barriers to access to services for these men. So what about the biology? The biological factors turn out to be incredibly important in understanding these epidemics. Is this mic working for people? Can you hear me? Okay. So first and foremost is a reality that has nothing to do with being gay, but has to do with the colon, which is that the per-act transmission probability in anal sex, irregardless of the gender of the receptive partner, is just much, much higher than for vaginal sex. The best estimate, and this is from the Bagley modeling that has recently been updated, is 1.4 per act transmission probability in unprotected anal intercourse. That is 18 times the biological transmissibility or probability for vaginal sex. So that is hugely determinative, and again, that is the same regardless of the gender of the receptive partner. Over time, that leads to a 40% per partner probability for couples who practice this behavior. So that, again, is an extraordinarily high per act transmission probability. The usual numbers that people use for vaginal intercourse, anybody know the per act transmission probability? About 1 in 1,000, right? So really markedly lower. And then, of course, there's the reality of what we are calling here sex role versatility. So you're all adults. Everybody knows that in heterosexual sex, the insertive and receptive partners are biologically determined, right? You with me? All right, good. Now, but with men, that is not the case, right? You can be both the insertive and the receptive partner in the same partnership, in the same evening, and of course within wider networks. That turns out to dramatically increase the transmission efficiency of HIV at network levels, right? It's a very important parameter. So we wanted to take these biological, structural risks, the behavioral risks, and try and think about this in some innovative ways to get a handle on the dynamics driving these epidemics. And to do that, agent-based stochastic modeling has proven to be really a powerful tool. And Steve Goodrow, who's working with some of your colleagues here, is a tremendous modeler at University of Washington. So we enlisted him and my former Hopkins colleague and friend Ron Brookmeyer to work with us on this model. And this, again, is in the Lancet paper. And we started with a counterfactual experiment. Right? So here's how the experiment works. You say, if anal sex were as infectious as vaginal sex, so we're going to parameterize a model. We actually parameterized it for urban and rural US and urban and rural Peru populations of MSM. And let's just say that the transmission probability isn't any different. How much smaller would the HIV epidemic be if we just change that? Everything else stays the same. The numbers of partners, the numbers of guys who are using substances, the number of people who have extra primary relationship partners, the number of people who pay for sex or are paid for it, the STI burden, everything else. And happily, all of this data was parameterized for the PUMA, Prevention Umbrella in the Americas trial that Susan Buckbinder is leading. So we already had all of that work done in advance. So I won't get into all the details, but just suffice to say that this is a very well parameterized model, and it really does accurately describe the epidemics. The idea is that you create an idealized population. We're using an N here of 5,000 men. We started with an HIV prevalence of 15% because that, unfortunately, is where the US and Peru both are in MSM epidemics. And we're looking now going forward at a 5-year incidence projection. So here's what you see, and here's my pointer. This is the 5-year reduction in incidence over time. And if all we do, and you're looking at urban US in blue, urban Peru in red, and these are urban US and Peru with adding high levels of testing and treatment. So a third of the men who need HIV testing and treatment are on it. So we, again, tried to model this based on an optimistic scenario. In fact, unfortunately, it's about 22% of US populations actually have those levels of care, and it's lower for MSM. So this is a slightly better scenario. You don't have to worry too much because, of course, the findings suggest that all of these scenarios matter very little. If you change the infectivity of anal sex to that of vaginal sex, 80% of the MSM epidemics go away. Right? So that starts to look a great deal like heterosexual transmission in those same populations. Now this is what happens if you play around with role segregation, and the idea here is to say in this population of 5,000 men, half the men are going to be insertive, half are going to be receptive, and nobody switches roles. So that, again, is like a heterosexual epidemic setting. And what you see is that you actually do get some changes. You get reductions of up to perhaps half the population, lower in, for example, in Peru, because there already is more sex role segregation among MSM in those settings. This we really just did as a standalone because obviously nobody is going to change their behaviors in those ways. It's just an exercise. But when we put those two parameters together, so vaginal infectivity and role segregation, you now are basically modeling what HIV looks like in a network of heterosexuals, and basically the epidemic goes away. That tail, which ranges between about 2% and perhaps 8% of transmission, is what is explained by behavioral differences, right? And of course, that has been the enormous focus of our interventions. Okay. So just to summarize this, and I've gone through it in some detail, the transmission probabilities play a huge role. The role versatility plays a very important role, and it can explain about between 15 or 20 and 55% or so of the epidemic. I didn't get into the stable partnerships, but reducing unprotected anal intercourse in stable partnerships also had some impact, but relatively modest. So what does that say? I think what it says is that we need preventive interventions that can reduce infectiousness and that can reduce the probability of acquisition in unprotected sex. So just hold on to that. When we get to the prevention part, we'll talk about what those might be. Now, sorry, am I too close? Pull it away. Is that better? Sorry. So now, if you look at the sub-epidemic among black MSM, and the related health disparities, I think what I've just taken you through starts to appear more clearly, and I think this helps us understand what's going on. So here you're looking, this is data from the CDC on young MSM in the United States, age 13 to 24, rising, but rising relatively slowly in white and Hispanic young men. This is African Americans, right? Completely different trajectory. Now, this is a beautiful systematic review and meta-analysis by Greg Millett and colleagues in the Lancet series. And essentially what you're looking at here, these are odds ratios across the bottom. The line for unity, unfortunately, is not appearing very clearly in this. But it's here, if you could see it. This is 1. So everything to the left of this is lower risks. And essentially what you see is that this is comparing black to other MSM, is that in terms of discordant unprotected anal intercourse partners, black men have fewer, they have lower numbers of sex partners, they have less receptive anal intercourse, and they have markedly higher HIV rates. Right? So it's a very counterintuitive finding. For comparison, they also looked at black versus other racial and ethnic minority or majority MSM in the UK, where there's better universal health insurance, but actually the same pattern holds, although the rates are markedly lower. This is an analysis, again, from Greg's group, looking at structural level experiences and resiliency, comparing US black MSM to other MSM. And here you have HIV prevalence, and these are summary odds. Lower education, markedly higher rates in black MSM with HIV. Lower income, ever incarcerated, an important factor. Unemployment, still giving you an odds ratio of about 1.5. Any structural barrier, over 2, over twice as likely to be HIV positive. But happily, any resilient behavior also markedly better for black MSM. So the structural barriers really are important. Sorry. And when he put this together and looked at the famous treatment cascade, here again you're looking at disparities between black and white MSM in the United States across this treatment cascade. What you see is that black men are much more likely to have undiagnosed HIV. That's a 6 up there for those of you who can't see it. About 6 times as likely to have undiagnosed HIV. About 2.5 times as likely to be HIV positive. Markedly lower levels of health insurance coverage, of ART utilization and access, of starting CD4s, starting ARVs above 200, which we of course would like to see, much lower rates. ART adherence is a bit lower. And the bottom line for HIV suppression is that they of course are much less likely to have suppressed HIV infection. Now if you think about the effect of treatment on prevention, and the network issues that we looked at before, what you are seeing here is a much greater likelihood of untested and untreated HIV. Now he's added the structural barriers to this, health insurance coverage, lower income, which moves across all of these, and healthcare access, which is also markedly lower. And I think we begin to get a handle on why that epidemic is so much more severe. So what are we going to do about it? Well, this is Patrick Sullivan's very elegant work looking at interventions, efficacy, and evidence. And what you have here is behavioral interventions basically in blue, biomedical in green, the one structural one we have in this brown color. The size of the ball is about the strength of the evidence. So we have very strong evidence, but unfortunately, we're starting here with the lowest efficacy. The biomedical interventions have weaker evidence because most of them are relatively small trials. In the case of PrEP, for example, just one trial. But their efficacy is higher, and of course the highest efficacy is for antiviral therapy. But that has been evaluated in discordant couples, not yet in MSM. There's also a tremendous bias, if you look globally, in where these data come from and what we know about effective interventions. So this is a global summary map. The size of the ball here is about the size of the populations that have participated in these studies. What you can see, for example, is the purple are below 100 MSM. So there have been a bunch of trials, but with very small numbers of men. And as you can see, most of what we know is from the US, and obviously it's a big, diverse world. Now here, again, Steve Goodrow was the modeler looking at modeling prevention impacts, again, agent-based stochastic, using several countries, and this time using original data from Kenya and India to add to the US and Peru, and really looking at the three preventive interventions that from the literature suggest would be the most likely to have an impact here. PrEP, treatment of positives, and increasing condom use through condom promotion and lube, and doing that at community level because there's better evidence for the efficacy of that than at individual levels, and now looking at outcomes over 10 years. And what you can see is that PrEP has some ability across all of these countries to reduce HIV incidence. And this, by the way, is set at about 40% adherence in PrEP. That, of course, is based on the IPREX trial, the first trial we have of evidence for efficacy with PrEP. This is early antivirals, and again, it's 40% coverage of early treatment for HIV, and a very disappointing outcome, in fact. We thought that that would have a bigger impact. We can talk about why that might be. And then condom promotion, which varies across countries and obviously has the biggest impact in a place like India, where condoms and appropriate lubes actually are a challenge for people. This is looking at, and maybe just in the interest of time, I won't go into it into too much detail, but this is the MSM infections averted by early antiviral therapy, looking at coverage levels. And we're tried to see in this exercise if coverage got a lot better, could we bump up the impact of antivirals for MSM? These again are the same four countries that you're looking at, the US, Peru, Kenya, and India. And what you can see is even when you get into very high coverage levels, 60 to 80%, we're still not getting over a third of infections averted. That, I think, is a real challenge for thinking about the impact of treatment as prevention for this population. These are PrEP data doing the same thing, trying to get up to extraordinarily high levels of PrEP, 90% in the green across these countries, and best case scenario, about a 35% reduction over 10 years in new HIV infections. So each of these in and of themselves is not going to get us there. Okay? Don't be depressed, but it just means that there is a great deal of work to do in this field if we're really going to turn this around. But obviously there are other threats to prevention, and it's not just that we don't have the strongest technologies. There also are tremendous forms of stigma, homophobia, and prejudice out there. There's threats of violence and very real forms of violence. There's a huge lack of training of healthcare workers, particularly in developing countries, with any expertise in providing services to these populations. There's criminalization in a number of countries, sometimes with quite severe penalties. Many of you know that Uganda is debating a death penalty bill for homosexuality that has gotten out of committee, may be passed. And there are, of course, technical challenges to putting together prevention packages and trying to get those out there. This is work that we did in Namibia, Botswana, and Malawi, looking at the impact of healthcare level discrimination on access to care for men who have sex with men. Former graduate student of ours, Heather Fay, and I'll just show you, for example, that when we look at men diagnosed with an STI or treated, ever tested for HIV, men who reported a self-diagnosis, if you look at things like fear of seeking health care, It's an extraordinarily common behavior or anxiety. Actually being denied health care services because of being gay was an experience of about 7 times more likely for men who had an STI, much more likely for men who were diagnosed with an STI, extraordinarily commonly reported by men who reported themselves being HIV positive. And when we looked at this blackmail parameter, blackmail, by the way, came out of our qualitative work. For those of you who do qualitative work, it is still vitally important to do that. We asked men what their issues were, and this kept coming up. We didn't really understand it at first, but basically the way it operates is if people disclose their sexual orientation, then healthcare providers insist on money or they will disclose that to other people, right? So obviously if you know that that's going to happen or if a clinic gets a reputation for that, it kind of inhibits people's willingness to talk openly, right? So that's what we're looking at. And just for example, anybody who's told that they needed an HIV test, almost twice as likely to report having been blackmailed. Men who self-reported they were HIV positive, about 5 times as likely. And that really is just very fundamental to why provision of services for this population remains such a challenge. This is from the newspaper in Uganda. More homos' faces exposed, and what this Rolling Stone paper has been doing is listing the names and home addresses of gay men, right, and getting people killed. So what can we say about prevention for this population? Our historical approaches and individual level behavioral interventions really are not working. Best case scenario with our modeling is that with the tools we have today, we think we can reduce 25% of new infections in MSM over the next 10 years. That's good. It's important. It's a great goal. It's not the finish line, right? And maximizing preventive interventions is going to include some smart prevention packages, but really also structural interventions, right? And by that we mean dealing with some of these sexual minority human rights issues. So, gay men, their allies, LGBT populations have been fighting a human rights fight around HIV since the beginning, right? These are some images from ACT UP, great graphics from AIDS Demographics. This is David Kato, the Ugandan leader who was murdered. This has been a long-standing fight, and it's not over. It's remarkable, actually, when you look. When we modeled and then did a cost estimate around that condom and lube provision, worldwide, the price tag is about $134 million. Sound like a lot of money? Right? I mean, actually, it's cheap, but it's not happening. And a lot of the reason it's not happening is homophobia. Now, when we think about clinical care and clinical care interventions, this is going to be a huge part of the future and what needs to happen. Because right now, in so many of these settings, men are being excluded or exclude themselves from care because of their sexual orientation. And in this country, thanks to the survival of the Affordable Care Act, we're going to extend health care to 37 million Americans, depending on which states agree and go along. And many of those folks are indeed people at risk, young LGBT folks, and they are going to be challenging to our healthcare system as well as they come into it. The U.S. has changed its policies. Poor Condoleezza Rice had the job during the Bush administration of standing up and saying, we stand with Iran in opposing human rights for LGBT populations. That has changed. This is a direct quote from Hillary Clinton at the UN Human Rights Commission in Geneva. And for those of you who remember her famous formulation in Beijing, women's rights are human rights and human rights are women's rights, she echoed that with this, right? Gay rights are human rights and human rights are gay rights. Could I have a round of applause for that? Yeah. All right. For Hillary Clinton. Yeah, and I must say that Secretary Clinton is giving this morning her last major AIDS policy speech. Can't wait to see it on YouTube and suggest you all do too. She's going to lay out the blueprint for an AIDS-free generation, and she is going to focus on key populations, including MSM. So when we looked at this in terms of what are the human rights principles and treaties and so forth that are out there in support of inclusion of sexual minorities in HIV care and services. Really, it's hard to do better than the Yogyakarta principles. And for those of you who are not familiar with these, this was an attempt by a distinguished group of international jurists to go through all existing human rights law through the lens of which of the elements of it really spoke to LGBT rights. And I will just highlight for you that several of these rights domains that we thought were particularly relevant for addressing human rights for sexual minorities. First of course, is that universal, most of the human rights documents are indeed universal, and they spell out at the beginning that all human beings are entitled to these rights. So unless you take the position that some governments do, that homosexuals are not human beings, there is really a universal basis here. Right? The second is the highest attainable standard of health, again, reiterated through a number of conventions and treaties, and very much strongly supporting that everybody has a right to the highest attainable standard of health, and certainly for MSM, that's a critical one. Protection from medical abuses is in a number of human rights treaties, and of course exclusion based on sexual orientation or gender identity is a medical abuse, right? Blackmail is a medical abuse. So that one really matters. And then interestingly, particularly now as we are entering the era of the struggle for marriage equality, the right to found a family is a fundamental human right, and one that certainly relates to our concerns. Of course, if you want to talk about human rights and get into the cultural, social, religious challenges we face, there's no better religious leader on this issue, I think, particularly in Africa, than Archbishop Desmond Tutu. So we asked him to provide a comment for the last paper in this Lancet series, which he did, and which I'll read to you in a moment, but I'll just say that when this whole series went live and we had the international conference, so many people were there, we thought everybody was going to be excited about our stochastic agent-driven modeling, Isn't that just the best part, But in fact, the quotes from Tutu are what went viral, right? And it went viral, first of all, because he's such a recognizable voice, but also because very deliberately, right, we asked him to speak to these fundamental issues. And we particularly wanted him to address the youth issue because, of course, all the data suggests that young sexual minority folks are at such high risk. For the LGBT youth out there who are struggling, who are made to feel inferior, let me say this. God loves you as you are. He wants you to live and thrive. So please take care of yourself, educate yourself about HIV, protect your partners, honor and cherish them, and never let anyone make you feel inferior for being who you are. When you live the life you were meant to live in freedom and dignity, you put a smile on God's face. Yeah. He should always have the last word, in my view. I just want to end by thanking so many of my colleagues, students, funders who supported this work. The epidemiology paper was a very distinguished group of colleagues, including Steph Barral and our group at Hopkins, Fritz Van Greensvan, Steve Goodrow, and Ron Brookmeyer. You can see the Black MSM authors that Greg led. The prevention paper included Alex Carballo-Diaz and Tom Coates, Steve Goodrow again, Jorge Sanchez, and this call to action paper, all the lead authors for the series, but then several other folks who agreed to participate with us. And I would just point out Eli Katabira, who is a Ugandan physician and was president of the International AIDS Society, immediately agreed to sign on and helped us with this. And that, particularly in the context of Uganda, is a real act of courage, which we appreciate. This work was supported by AMFAR and by the Bill and Melinda Gates Foundation, and also by the Hopkins CFAR.